Welcome, everyone. Thank you for joining Continuous Learning with Bioguard. It is my pleasure to introduce our webinar speaker, Dr. Chen-Si Lin. Dr. Lin got her DBN degree from National Taiwan University and her PhD from the College of Biological Science and Technology, National Taiwan University. She's a professor in the Department of Veterinary Medicine and Director of Zoonosis Research Center at National Taiwan University. In addition, she's a former Director of the Animal Disease Diagnostic Center at National Taiwan University. Her specialty include veterinary clinical microbiology, clinical pathology, and animal cancer biology, and therapeutic development. As everyone knows, liver is crucial for numerous vital physiological processes, such as metabolism, regulation of excretion, immune response modulation, protein synthesis, and energy storage. Testing liver function is essential for assessing liver health and diagnosing diseases. Thus, understanding and monitoring liver function in dogs and cats is critical for maintaining their overall health. In today's lecture, Dr. Lin will guide us through the intricacies of liver function testing. We are delighted to have her as our speaker for this webinar. Now, without further delay, let's welcome Dr. Lin.
Thank you for the introduction from Dr. Ruo. So I'm Lin Chen-Si from National Taiwan University, and it's my pleasure here to share the liver function test during the next maybe next 60 minutes. I think in my previous lecture, I've introduced about the liver, the physiology, anatomy, and about liver. So today we'll focus on the test related to liver functions, and these functions may guide us. This test may guide us to probe which part of the liver may have some problem, and maybe we can, it will help us to find a solution to fix these liver diseases. Okay, so I'm sorry, I think there's some technical problems occurred in my laptop, and I just mentioned that actually, I just briefly introduced about the blood supply of liver, and I've mentioned that actually here is the hepatic artery, and here is the portal vein system. And the portal vein system actually mainly deliver around 80% of the total hepatic flow. So that's why when portal systemic shunt occurred, the liver will become smaller, because some of the growth factor actually is provided by pancreas. They will also delivered by the portal vein system. And the other part is because when portal systemic shunt occurred, less blood will enter the liver. So that will also that is another reason to result in the smaller liver that we so-called microhepatica. So let's move to the next slide. So now, so since we've talking about the blood supply, so when we look up if some problem or some cases we are worried about if the symptom related to a liver problem, we need to not just look at the liver itself. We need to think if this liver hepatic problem is resulted from second to other diseases, such as if the patient are suffer from, or the patient has the history of cardiovascular insufficiency, this will result in some secondary liver diseases, because just as I said that the blood supply is basically from hepatic artery. So if they have the CVS problem, the blood to supply liver will also decrease. So it will result in some liver symptoms to be found. And another, if the CVS patients, this will also cause hypertension of the systemic vein problem, and then will result in the hypertension of the portal vein system. So both way, either way, if the patient has a CVS problem, so it will generate the secondary liver diseases. And other reasons we should focus if the other causes will result in the liver function change or liver enzyme changes will actually include anemia, portal systemic shunt, or GI infection. These causes will also to result in liver problem, and we can see the changes of the liver enzyme or the abnormal functional tests. So we will mention about the portal systemic shunts, and this is the symptom actually. This is the problem occurred in our portal vein system. So basically, the portal vein, it provides around 80% of the blood into our liver. However, in some reasons, and these reasons partial will there are basically two reasons. One is congenital portal systemic shunts. Another one is acquired PSS. So for the congenital PSS, this kind of portal systemic shunt is idiopathic, and it's the genetic defects in dogs and cats. So this kind of PSS actually is the common type. Is much more commonly found in dogs and cats. Another PSS is acquired one. And acquired one actually is uncommon, it's less common in dogs and cats, but sometimes we can find. And in this case, usually it's a chronic, it's a long time disease progress. Maybe this dog or cat, he or she is suffered from chronic liver disease. And this chronic disease, liver disease cannot be well treated, and then will result in necrosis of hepatocytes, and basically, and gradually, actually, this hepatocyte, when they are gradually damaged, and then inflammation occurred, regeneration occurred, but some part of the hepatocyte were replaced by fibroblast. That is so-called liver fibrosis. Over to this severe condition, it will become cirrhosis. So this is the very need a lot of time, and it's the chronic liver problem. So, and when the liver becomes cirrhosis stage, then actually most of the hepatocytes were replaced by fibroblast. Okay, so I'm showing the slide. Can you see the slide share? Okay, so I'm talking, I just mentioned about the portal systemic shunt actually is from there is two reasons. One is congenital and the another one is acquired. And I've explained the reason cause acquired PSS. So but this case is less common. And for the congenital, most cases we can find maybe is result from congenital PSS. And also this shunt means the division of the new blood vessels genesis. So you may find shunt, and you may find this new blood vessel within the liver or outside the liver. And for this kind of for the PSS treatment of PSS, you should identify where the blood vessel generated. And basically, we can use surgery to fix the problem. But we need other treatments, such as we need to take good care. We need to have some kind of a diet management to have this kind of the animal, especially the protein management, because when this kind of animal suffer from congenital PSS or acquired PSS, because their liver cannot function normally, and so if this patient, they don't have some kind of concern such as the hepatic encephalopathy, and so if they are not in this case, so we should have take good care of their diet, and this diet they need to have a proper maybe we can say enough protein contents in their diet, and to help them gain enough protein before the surgery or after the surgery. So why we stop, we can stop to talk about the portal vein or portal blood, and that is why the in the portal blood they actually contain a lot of important things, and most of them are the nutrition observed from the GI tract. So actually all these molecules such as amino acid, glucose, and the fatty acids, actually they are important to us. They need to processed in the liver, and then to be transported to into our they need to transport it into the systemic circulation, and then to support to our all the cells within our body. And they also contain the bile acids. Bile acids actually is important in digestion, and it's also the major component to trigger the digestive process. So it will also actually will also recycle after the digestion is finished. And in this portal vein, we can also have some intestinal antigens. Actually, some of them are pathogens. And so this kind of antigens or pathogens, when they come back to the liver in the portal blood, and actually in our liver, we have some of immunocyte. Basically, like the major part is Kupffer cell. It's kind of macrophage. And these macrophages, they can process this antigen. But also in liver, we have some lymphocytes also, or dendritic cell or NK cells, and this kind of cells, they can help us to eliminate these pathogens or antigens that might cause potential damage or infections to the individuals. Okay, so we were talking about this kind of portal systemic shunt, and we also mentioned that because in portal blood they have some growth hormone produced by the pancreas, that's so-called pancreatic hepatotrophic factor. So if the patients suffer from PSS for a long time. So the final outcome will be hepatic atrophy, and that's what we call the microhepatica. That means this liver becomes smaller than the normal cases. So if we want to measure some kind of if we want to detect if the liver is healthy or not, we can analyze different kind of items. Such later we will introduce ALT, AST, ALKP, or we can do some liver function tests such as bile acids, such as total bile acids, total protein, total glucose, and so we can use different kind of testing panel with the confidential biochemical analyzer. So such as Bioguard will provide such kind of analyzer as accompanied with the testing panel, and that's the choices that for the clinicians that you can choose for a test. So for the hepatic test, we can divide for the 5 major parts, and we can detect the pigments such like bilirubin or urobilinogen. And bilirubin, that's why we so-called. If the case with liver problem, one of the symptoms we can find is the jaundice or the icterus. And jaundice icterus, and you can find them, the patient, they may have the yellow color in the skin or in the mucosa. However, sometimes if the jaundice is not so severe, you cannot find this appearance in the skin or mucosa. However, if you want to do some biochemistry analysis, you collect the blood to obtain the plasma or serum, and then you can find this serum or plasma sample that become a little bit yellow. So if this case occurs, actually it means the bilirubin metabolism actually is something wrong to the bilirubin metabolism. So there is a circulation, the bilirubin metabolism occurred in the liver, in the hepatocytes. So later we'll introduce. And also because a liver responds for the lipid metabolism, so if liver problem occurs, you can also find the abnormal higher or lower changes of cholesterol, bile acids, and the triglyceride. Since hepatocytes is the major hepatocyte produce bile acids, and so these bile acids will help the metabolism of lipids, and then the lipids, they can become triglyceride, and some of them the lipids will also help the absorption of cholesterol from the GI tracts. So if liver problem occurs to some medium to severe degrees, you can find the abnormal changes of these lipids components. And the third part would be protein. And as we know that liver actually is the major, or we can say the only source of albumin and the coagulation factors. So if maybe around 30% of the hepatocyte of liver cell are damaged, if more than 70% are lost, the hepatocyte lost the functions, we can find hypoalbuminemia, or we can find the lack of coagulation factors. And this will also result in the abnormal albumin to globulin ratio to be, you can find this phenomenon. And because in the intestinal, in GI tract, they will digest the protein, and one of the byproduct of the protein digestion metabolism actually is ammonia. But ammonia actually is toxic to mammals. So this ammonia generated in GI tract, they need to bring back to the liver, and in the liver, they will do the urea cycle to transfer ammonia, to fix ammonia into urea nitrogen. And the urea nitrogen is then they can circulate in the blood and eliminated by the kidney. So if the liver problem occurs, they cannot transfer ammonia into urea nitrogen. So these cases, you can find the ammonia increases in the blood. It's abnormal and it's dangerous to the animals, because if ammonia is toxic to cells, especially to neurons. So if there is high blood in ammonia, and the patient may suffer from hepatic encephalopathy. So this is the major part we were introducing in today's lecture. And there, though we can find there is also some specific test, and basically this is dye test. And because this test they are processed in the similar pathway, such as bilirubin. So right now, actually, we can monitor bilirubin only, and we seldom do this kind of BSP test or ICG test, because actually this kind of BSP or ICG material, they are also a little bit toxic to the hepatocyte. So if the patient, their liver function are abnormal, and they are subject to this kind of tests, it may to have the cases to go to the much worse situation. And there is the similar reason to the ammonia tolerance test. If the patient are in a severe liver problem, they cannot suffer. They cannot suffer from more ammonia. So this specific test, actually, we saw them perform in clinic. So I think I may introduce this kind of liver enzymes before, and I think you're already familiar with this enzyme. So I will gonna to briefly introduce these enzymes to you, and just to focus on in this enzyme, what kind of problem this enzyme will indicate to us. So the first two will be ALT and AST. The ALT and the AST in cats and dogs, they are very commonly used to indicate if there is any problem to our hepatocytes. So if some kind of hepatocellular damage or some kind of necrosis of the hepatocyte, you can find the increase of ALT and AST. So basically, these two enzymes very commonly used in dogs and cats. So the thing we need to maybe pay attention will be the ALT, the health life of ALT actually is a little bit short. So it means that maybe sometimes we can find AST increase, but ALT is not increased so high in cats. That's maybe because of the shorter half-life. So ALT, yes, it's together with AST to indicate the hepatocyte damage to us. So what kind of this will necrosis or something occurred to result in hepatocyte damage, you can find the ALT and AST increase. But this is for dogs and cats. Yes, and here we are here the mention about sometimes the muscle necrosis will also result in the increase of ALT, but this case will only occur in severe muscle disease. Actually, AST is also produced by muscle, and also it could be seen, it could be viewed as the indicator for muscle damages in AST, but it's much more sensitive than ALT. So actually, in this case, only severe muscle disease will result in increase of ALT. So and I think if you are concerned about the muscle problem, you will have other indicators to help you rule out this disease, such as CK. This kind of enzyme is specific for muscle disease. So when we focus on liver problem in cats or dogs, if we want to identify this problem is coming from necrosis or hepatocyte damages, you can trust ALT and AST. And commonly we will use both these two enzymes together to help us. Because this enzyme, if these two enzymes, they are increased simultaneously, it will with the high probability of liver problem. So though you need to do further tests, or including the image test to help us to do the final diagnosis. So this for dogs and cats. And if we focus on horse, ruminants, pigs, and birds, we need to notice that the liver ALT actually is very low in this kind of animal. So if your patient belong to this kind of animals, horse or ruminants, you cannot use ALT. This for AST, as I just mentioned about, actually there is a lot of there is some amounts in skeletal muscle. Also, AST exists in skeletal muscle. So basically, we will test ALT and AST together in dogs and cats. And if they increase together, and this is very high possibility for liver injury. So for the horse and the cattle, since we've mentioned that they don't have liver ALT, so in horse and cattle, we can use AST to monitor the liver problem. But if you are not confident, because AST is also they can also come from the skeletal muscle. So in this case, for horse or cattle treatment, you can use SDH. This another liver enzyme within the hepatocytes. So SDH and the AST together can help you to identify the hepatocyte damage in horse or ruminants. So when we measure this kind of enzyme, we also we usually will use plasma. So we need to pay attention that our plasma sample we need to make sure that this sample they are clear. We cannot have hemolysis, or we can not have lipemia in the plasma, because they will cause the not correct value. We cannot obtain the correct value of ALT and AST. And also we need to rule out if this animal, they are taking some specific drug, such as phenytoin, primidone, and phenobarbital or glucocorticoid, because this kind of drug, they can induce the increase of the ALT. So before we try to interpret the data of ALT of all this interpret all this clinical data, we need to fully understand the history of this animal, So such in this case, these drugs, they can induce the increase of ALT. And on the other way, cephalosporin, they can decrease ALT. So the drug history is important. So we mentioned about the enzyme related to hepatocytes damage. So the next part will be the ALP or GGT. Actually, this kind of enzyme, you can use one of them or you can use both of them. It's okay. And indicate the impact of the biliary system or bile duct system. Because in liver, the major part is hepatocyte. However, a hepatocyte will produce the bile acid, will produce the bile. So we need the bile duct system to help us to transport this bile or bile acid into the another part to store into the storage to store this bile. So ALT and the GGT actually is they are located on the epithelial cell of bile duct. So if the bile duct system are damaged or they are have some inflammation cases, we can find the increase of ALP and the gamma GGT. But I think an ALP, most of the ALP, they come from the hepatocyte, just like here. But there are still some other organs they can produce ALP, such as intestine and bone. So, but the issue will be the ALP come from bone it only occupy less amount. So maybe we can ignore this. And for the intestine ALP, they had a short lifespan. So basically, the major ALP, they are come from the here say hepatocyte actually is from the it's where basically located from the epithelial cell of the bile duct system. So that's what this is why we can use ALP as the indicator of if to realize if the bile duct is good or not. Okay, so it's a good indicator of liver disease and the cholestasis. Cholestasis means the bile accumulated within the bile duct system, or the most severe condition, they will draw back to the liver. And it's a bad situation. And if the severe cholestasis happens, it will gradually to damage the hepatocytes. So it's a condition that we need to pay attention, and maybe we need to fix in the early timeline. Okay. So for the cholestasis, we not only can find the increase of ALP, we can also find the high concentration of bilirubin in the plasma. So this is in dog. In cat, the ALP they have the ALP in cat is with the short half-life. So any increase of ALP actually is significant, is meaningful for us to diagnose the problem of the bile duct system. So ALP is important for the bile duct cyst problem, and also is a sensitive indicator of cholestasis. However, there is the condition that we need to pay attention for ALP in dogs. I mean, only in dogs, because if the dogs they are subject to glucocorticoid treatment, or they have some such as how we say Cushing syndrome, because in Cushing syndrome they always has the high concentration of corticosteroids, glucocorticoids. So this kind of animals, of dogs, they will have very high ALP level. such as maybe more than 1,000, the value will be over 1,000. So if we found only very high ALP increase without other symptom related to cholestasis or biliary duct damage, what I said, such as you can only find ALP, very high ALP jump without bilirubin increase, without jaundice, without some because the bile duct problem will result, then they will result in digestive problem. So if you don't find any clinical symptoms without digestive system or jaundice and without the increase of bilirubin, you only found very giant increase of ALP. So in this case, maybe it's not the liver problem, and you need to look up if this dog they're subject to some kind of corticosteroid treatment or some kind of glucocorticoid induction. So another enzyme you can use to indicate the bile duct problem will be GGT, and it has the similar meaning to ALP. And for GGT, there is another function for GGT. If we test GGT in urine instead of plasma, it will help us to identify if there is any kidney problem in the tubular system, because GGT also located in the tubular epithelium cells. And so if we test the GGT in urine, not in plasma, it can help us to identify the kidney damage. But what we talk about when we look back to liver, GGT in plasma, if GGT in plasma increased, it will help us to find out that there might be anything wrong to the bile duct system. So here, because we just mentioned that ALP in cat, they has the short lifespan. So you can, in cat, if we want to locate the problem related to bile duct system, you can detect both ALP or in the GGT together in cat. So there are some figures I want to share with you to identify if what we can use this kind of enzyme to help us locate which kind of damage occurs. So in this figure, this typical the liver enzyme and biliary duct enzyme changes. This figure is about the acute injury of the hepatocytes. Since this injury or damage occurred in hepatocytes, so we can find the rapid increase of ALT and ST. But gradually, you can find maybe in the first 24 hours, the giant increase of ST and ALT could be found. But gradually, if this kind of damage could not be fixed in the right time, and then you can find the mild increase of the ALP. That's because hepatocyte, the biliary duct actually is very close to hepatocyte. If we review the anatomy of the liver, and so this kind of damage, they will kind of hepatocyte damage, they will gradually affect biliary duct also. And this is another case, and this is about the chronic injury. The previous slides talking about acute injury, but if this kind of injury could not be fixed well, so we can see always the fluctuation of ALT and ST. That means there is chronic and continually injury of the hepatocytes. So there may be hepatocyte necrosis, inflammation. So if you also look up at the blood cell or white cells value, you can find there may be the increased white blood cell count. That's because the inflammation occurs here within the liver. And then inflammation necrosis, and then fibrosis. So that's why we call it the chronic injury of the hepatocytes. So since if the disease progresses into the fibrosis or cirrhosis stages, the hepatocyte will be replaced by fibroblast. So you can see, although there are always fluctuation, increase of ALT and AST, but the increase will gradually slow down. Will gradually become less not so high compared to the very beginning. So that means we are losing this hepatocytes, and then this liver is going to the fibrotic stages, go to cirrhosis. So this is very not good situation, because this kind of damage cannot be reversed. Actually, and at the same time, we find the increase of bile acid in the blood. However, it's extremely abnormal because of bile acid, they could not be detected in the blood in healthy animals. Okay, bile acids, they will be circulated between the intestine and the liver, and they cannot go back to the blood. So if they do, if this bile acids, they do exist in the blood, that means this liver, actually, most of the liver hepatocytes are damaged, and the liver are lost the major functions, so they cannot process all the normal, such as recycled bile acids. So finally, this bile acid will enter the blood. So this is the typical chronic injury figures that we can see. The ALT/AST, finally, we cannot detect them. Because all the hepatocytes, they are disappeared or replaced by fibroblasts, and because the most of liver cells, they are lost of function, so bile acids are in the blood. And this case is the cholestasis, or the problem occurred to the bile duct. So we can see the first increased at the highest concentration of ALP as found in the blood. However, because it's the bile duct problem, so they will gradually affect hepatocyte. So right now in this situation, such as during the during the first week, we cannot find very high increase of ALT and AST. However, if we let this situation continue to develop, later we will also see the increased ALT and AST, because this cholestasis, this bile accumulate within the liver, they will gradually damage the hepatocytes. So it's the enzyme that we've used commonly to detect the to help us first and to identify if the problem occurred in hepatocyte or biliary ducts. Okay, so the functional test will be the albumin and coagulation factor, ammonia, and cholesterol. And for the albumin that I just mentioned before, albumin actually is only synthesized by hepatocytes. So if most of the hepatocytes, maybe around 30 or more than 30% of hepatocytes are damaged, then we can find a hypoalbuminemia. So that's what we want to say. So this is the reason that we can result in hypoalbuminemia. Maybe this hypoalbuminemia is result from increased loss, such as protein-losing nephropathy or enteropathy, or hemorrhage, or the extensive skin, such as burn. The skin is burnt. So this case, because this hypoalbuminemia will result from increased loss. However, for the liver cases, it's a severe liver problem occurred. It's will be the major reason to result in the low concentration of albumin in the blood. So if the patient, they are not suffer from the increased loss of albumin, you should pay attention that liver problems are here. So another factor produced by hepatocyte is coagulation factors. We can find here that only factor 8 are not produced by hepatocyte, only factor 8. So the other coagulation factors are produced by hepatocytes. And there is another reason, and there's another reason. And for the coagulation factor 2, 7, 9, and 10, they are vitamin K dependent. So if the bile flow, if the flow of the bile they cannot come back to the liver due to the cholestasis, and it means that vitamin K also cannot to be brought back to the liver. So in this case that this coagulation factors, they could not be well produced. So what kind of phenomena we can observe if these cases occurs? And we won't see the very obvious clinical symptoms. We won't see bleeding of these cases, but if you perform some coagulation tests, such as prothrombin time test, PT, or activated partial thromboplastine time, APTT, you can find the abnormal long time of PT and APTT. So if this case occurs, yeah, it means that the coagulation factor, it means the deficient of coagulation factors, and it could be one indicator to tell us that the function of liver is abnormal. And another factor is ammonia. Just as what I said, that ammonia actually is the metabolite from protein. So, but ammonia is actually it's toxic to our cells. So actually, we can find here that in intestine, this kind of protein, they will digest by our digestive system, and also the bacteria located in the intestine. And so the byproduct will be ammonia. And this ammonia will be transferred through the portal vein system. Here is the portal vein system, and come back to the liver. And come back to the liver, they will subject to the urea cycle. This urea cycle will help us to transfer ammonia into urea nitrogen. And urea nitrogen is non-toxic to our cells. And later, this urea nitrogen will be eliminated by kidney in the urine. But for the liver, for the patient suffer from liver problem, because most of the hepatocyte, they lost the functions, so they cannot perform normally. They cannot perform urea cycle normally. So in this case, on this ammonia, they cannot fix the urea cycle. So they will directly enter the systemic circulation. So just as I said, it's toxic to cells, especially to neurons. So this patient will show the typical symptom of hepatic encephalopathy. So this is one case if we got this kind of hepatic abnormal hepatocyte damage. So another cases will be PSS, portal systemic shunt. In portal systemic shunt cases, that this ammonia, they cannot because of the maybe of the portal hypertension, they cannot go back, and so they go and this ammonia will transferred into the shunt through the shunt via the new blood vessels, and this new blood vessel, they won't enter the liver. They will go directly into the systemic circulation. So this ammonia, it will cause the high concentration of ammonia here. So it's not normal when we detect ammonia in the blood. So if this talk about this kind of PSS. So this if we have the hepatocyte loss of function, or this some rare case we can find this congenital defect of urea cycle. So this case will all result in we detect ammonia in the blood. So for the high concentration in the blood, finally, this ammonia will also be they will also be excreted by kidney. So if we investigate the urine, we can find the ammonium biurate crystal in the urine. So if the liver, most of the liver hepatocyte loss of function, it will also affect the cholesterol balance. So both we can find hypercholesterolemia or hypocholesterolemia in liver cases. And another two, the last two functional test I want to mention about the bilirubin and bile acids. And bilirubin, I think all of you have already know that bilirubin actually is the downstream products, and it comes from the erythrocytes, red blood cell, and turnover. It comes from the turnover of the erythrocytes. This old erythrocytes will are removed by macrophage system, and all the hemoglobin will be metabolized into product will be the bilirubin, and this bilirubin was so-called unconjugated bilirubin, and they will enter the liver and to be converted into conjugated bilirubin. And this conjugated bilirubin later will through the bile duct system to go into the intestine. And in the GI tract, in the intestine, bacteria located within the intestine will further to metabolite bilirubin into urobilinogen and urobilin. And some of them will recant only, I think, only a little bit will recant in the GI tract. And the urobilin, the color of urobilin is yellow to brown. So that's why our feces, our animal feces, as the color of feces, they are present as the yellow to yellow brown color, and that's because the urobilin, the presence of urobilin. And also the major part of urobilinogen and urobilin, they will bring back to the liver, and maybe around 10% they will eliminated by the kidney. So that is why the urine sample from the animals, they will also, the appearance, the color will be also the yellow-brown color. So if something wrong, severe to the liver, and this cycle won't be processed very smoothly. So in severe liver disease cases, we can find that even the feces of these animals, they cannot show the normal color brown and the normal yellow brown color. We can see the gray feces. So gray feces if we found great feces of this animal, one of the major reason is the liver problem. So this bilirubin. Bilirubin actually, they, just as I said, if they smoothly processed by the liver, they will become urobilinogen. So we actually, in normal condition, in healthy cases, we won't see the increase of bilirubin. So if we find increased concentration of bilirubin, and even we found much more severe case, we found the jaundice of icterus in animals, that means the liver problem occurs. Okay, so actually jaundice could happen not result from liver problem. It also result from pre-hepatic or post-hepatic problems, but due to the time limits. So today we only focus on hepatic problems. So if we found the cases for the, because we always monitor different kind of parameters. So it could help us to rule out if this jaundice, this symptom, the icterus appearance, they are come from before liver or hepatic problem or after liver problem. Okay, this is what we said. This is severe cases, and these cases is the cat suffer from immune-mediated hemolytic anemia. It's a typical case of pre-hepatic jaundice. So you can see the brown, the yellow color in the skin of the cat, and also you can see this is the severe case. You can find not skin, but also in the conjunctiva, you can see the yellow color. So another and the final parameter I want to introduce to you is about the bile acids. Because I just said the bile acids is the major major components in the bile, and it helps us to metabolize the lipid. And after metabolism, this bile acid will recycle back to the liver. So in the normal condition, this bile acid could not be detected in the blood. So in other words, that means if we detect bile acids increase in blood, that means the liver function is abnormal or damaged. So we should do further tests to help us to locate the problem. Okay. So it's the multiple functions of bile acids, such as it helps us to maintain the normal metabolism for cholesterol. So that is why when liver problem occurs, maybe we can find hypercholesterol or hypocholesterol in different cases. And it will be as the driving power to drive the flow of the bile. And it will help us to metabolize lipids. And actually, bile acids is very powerful to eliminate the bacteria, because bile acids, it can, just as in the third point, bile acid, it will emulsifying lipids. So it means it can damage the, because in bacteria, they have the cell membrane, and they have the, though they have the cell wall, they also have the cell membrane. Cell wall, they also have some kind of lipoprotein. So this bile acid, they can damage the lipid component of bacteria flora. So that is why in cholestasis cases, what we talk about is cholestasis, the outcome of cholestasis. If we did not fix well, and later, this cholestasis will also result in damage of hepatocyte, because for the cell mechanism, bile acids, if we accumulate too much bile within the liver, these bile acids will also damage hepatocytes, because they just damage the cell membrane. So this is the some this bias test, and this is what we should pay attention, that we need to especially to take care of our sample, because we need to make sure that our sample is not hemolysis or lipemia, or you take or layer some, I just mentioned some drugs. This will cause the false increase or false decrease of this indicator that we've tested. So please pay attention to your sample and pay attention to the patient, the drug history, or what they have been through. Okay, so here are the major, I think hepatic necrosis, hepatic insufficiency. That means over and more than 70% of the hepatocyte was damaged, just as I mentioned before, and cholestasis and photosystemic shunts. These four situations are the common cases for the liver problem that we found in clinical sites. So for the hepatocellular leakage or necrosis, we can find the increase of ALT, AST, and SDH. So that's what we talk about. And if we do not pay good attention, it will finally outcome will become to the hepatic insufficiency. So we need to treat this. We need to fix this situation. We need to take care, need to protect these hepatocytes. So basically in clinical, we will suggest some kind of drug to protect hepatocytes, such as silabum, such as vitamin B complex, and methionine. These treatment options could provide good protection of hepatocytes. So in the early stage, if this animal come to our hospital and we found the mild to medium elevated the ALT, AST, and SDH, we can provide this kind of treatment options to help them to recover the hepatocyte. So if we do not treat hepatocyte damage well, then we will the outcome will become the hepatic insufficiency. Another case is cholestasis. Cholestasis actually may be due to the inflammation of the bile duct system, or maybe due to the some problem of the gallbladder or the common bile duct. And this cases may be due to some neoplasia, obstruction, infection, and cholestasis. These issues or some kind of different kind of infection, and this will result in cholestasis. So for the cholestasis, just as I mentioned, you can find the very significant increase of ALP and the GGT, as well as you can find the bilirubin and bile acids. This normally we cannot find the blood, but right now we can find a high concentration of bilirubin and bile acids. So in this case, if we want to fix this problem, the treatment suggestion will be we can use papaverine and cosphanone. This kind of drug will help us to try to it will help the relax of the bile duct, so you can relax the worst situation of cholestasis because it can release the bile duct. And if we have some obstruction problem, not cancer, such as here we can see about the cholestasis, this kind of obstruction, we can use ursodeoxycholic acid to help us dissolve this kind of obstruction. So this is what the common symptoms that we can find in liver and bile duct system. So this table, I just wanna, I think it's a very summarized table to help us quickly use different kind of parameters that we've mentioned in this lecture, and we can use the increase, decrease, and not show the different kind of parameter, and to locate the the problem, where the problem is. So these changes could help us to locate the cases if the problem occurred in hepatocyte or problem occurs in the biliary duct system. So I think it's a very summarized problem that the table to help us quickly figure out or to make differential diagnosis for this. So I'm sorry I just spent more than 1 hour to share the liver cases here. And if you want to know more information about the analysis test or the information about the update clinical information, you can follow the website provided by Bioguard. So here is my lecture, and thank you for your listening. Yeah, I'm sorry that in the previous maybe limits we have some problems about this slide sharing. So it's my bad. So I apologize for this inconvenience. And I am happy to take any questions. So I will say some questions here. Okay. Yeah, one question is about the GOT cases in rabbit. Yeah, I think actually I think in rabbit because what's GOT? I'm not sure about the rabbit issue actually. So maybe we can provide some answer later for about this issue, but I need to copy this question first. So I think later this PDF file will be uploaded in the website of Bioguard, so you can get it for PDF file. Another question is talking about the elevation of ALP or ALK or so-called ALKP. Why ALP or ALKP will be increased in portal systemic shunt? So in this case, I think in portal systemic shunt, this is maybe will result in acquired portal systemic shunts. And in this case, because the I think both hepatocytes in congenital portal systemic shunts, actually the portal vein and both the blood flow of the portal vein as well as the bile duct, because now this case, this liver is in severe fibrotic status or cirrhosis, or so-called cirrhosis. So both the bile duct system and the portal vein system, they are collapsed. So the bile duct system, they also cannot work well. So we can also see the damage of the bile duct epithelium cells. So we can see the elevation of the ALP. I got the question is about the how can we interpret bile acid tests in case of PSS. So maybe we can go back to So this slide can show us about how we can interpret the bile acids on why in polycystic shunt cases we can find the elevated bile acids. That's because in normal condition, the bile acid will uptake by liver. However, in PSS cases, because this blood in drawn from GI tract, they cannot enter the liver, so they will directly enter the systemic circulation through the shunts. So that's why we can detect the increased elevation of bile acids. So if we found, there's another question, if we found the jaundice, prehepatic jaundice, not hepatic jaundice. If we found prehepatic jaundice, what kind of liver enzyme that we may find? It's a good question. And actually, I think in common cases, because it's a prehepatic jaundice, and the most common cases result in prehepatic jaundice will be, that's what I mentioned, immune-mediated hemolytic anemia. So if we want to make differential diagnosis, you will see the IMHA, the symptoms of IMHA, as well as you can find a lot of hemolysis through the CBC examination. And however, lots of RBC destruction, lot of hemoglobin is produced. So in this case, because the liver, they cannot process so giant amount of hemoglobin, so you can find only mild increase our escalation of ALT and AST. That's because some of the hepatocyte, they cannot suffer from, they cannot work, so they are overworked, I think. So finally, they may go to necrosis. So we can see the mild increase of ALT and AST for prehepatic jaundice cases. So thank you for all your questions, and the GOT in rabbit cases, I can pass to the I will later maybe pass the message to the Dr. Luo and to give the answers to you. So thanks for your attention today, and thank you for your time. So I think today's lecture will end here. Thank you.
Yeah, thank you, Dr. Lin, for the outstanding presentation today. And thanks to everyone who joined us for this webinar. We look forward to seeing you at our next session. And good night.